Good morning and good afternoon. Thank you for joining us today. We're excited to have you on the line for this webinar. It is my pleasure to pass the mic over to Kevin Kumler, Virta's president. He is your host for today.
Thanks so much. And thanks everyone for joining and those who are watching us after the fact. Just a quick word on Virta for those of you who are new to us. We're leading the charge to reverse metabolic disease, namely type 2 diabetes, prediabetes, and obesity. We believe that people deserve the opportunity to have more than management of their disease and managing their condition. The opportunity for reversal should be available to all. So I'll quickly introduce our speakers that we'll have today. If we could flip forward and show our photos of our two speakers. The first is Dr. Amy McKenzie. She's the Senior Director of Research and Innovation at Virta. She's been part of our team for more than 7 years. And her research focuses on the intersection of nutrition and metabolism with telemedicine and digital health. She has a PhD from the University of Connecticut and a wealth of experience on our research here. Our second speaker is Michael Garrett. He's an independent health equity and clinical consultant. He has, which is shocking looking at both the photo and Michael's face, somehow has more than 40 years of experience in healthcare, largely in care and case management, health quality, and health equity. His experience covers employer-sponsored benefits all the way through a range of government programs. Most recently, he's been focused on identifying health disparities and inequities and developing and implementing health equity initiatives. He has a master's in clinical psychology from the University of Idaho and is board certified in case management, vocational evaluation, and patient advocacy. Really looking forward to hearing from both our speakers in just a couple minutes. Before we get into that portion, I'd love to zoom out quickly, and we'll talk a little bit about the disease that Virta spends most of our time working on the next slide. Type 2 diabetes is at epidemic proportions in the US. The CDC released their latest report on diabetes just in January, and it showed that we have more than 130 million American adults with diabetes or prediabetes. The root cause is ultimately insulin resistance in the body, and it's highly correlated with a bunch of other chronic diseases, from heart disease to joint pain to mental illness. Diabetes is now estimated in 1 in 7 adults and nearly 1 in 3 seniors. And while widespread across all of America, it disproportionately impacts people of color and those with lower socioeconomic status. On the next slide, we've highlighted a couple of items that many of you who are joining because you're passionate about the area are already aware of, but social and environmental factors play a large role in the likelihood for somebody to develop type 2 diabetes and also the impact of the disease on their health. 2 examples. Number 1, food insecurity. It's nearly twice as likely to be present in people with diabetes than people without diabetes. And drug affordability, when you think about treating the disease once it's present, nearly 1 in 5 adults with diabetes feel like they have to reduce or delay their medication due to cost. So not only are people more likely to have it, but treating it is more difficult due to these social and environmental factors. On the next slide is some of our data on prevalence here. Type 2 diabetes is inequitably distributed in the US. I had the privilege of joining the White House conference on hunger and nutrition last fall, where Senator Cory Booker from my home state of New Jersey shared his aspiration for the US to lead the world in strongest economy, strongest military, in innovation and education. But we currently lead all industrialized nations in diet-related diseases. And he pointed out further that in Black and brown communities, people are 77% more likely to get diabetes and twice as likely to die from it. And we believe that these impacts really need to be addressed at the root. Sometimes when we're sharing all these statistics, the human element can get lost. So just to share one specific example, and it's unfortunately one that I have personal family experience with, is amputation. Many of us may think of amputation as being associated with battlefields and explosions. The reality is that in the veteran community, more veterans have lost limbs to type 2 diabetes than all of America's wars combined. And these impacts are also inequitably distributed. One recent study showed in South Carolina, the variation in amputation across zip codes that were fairly close together was as much as 40 times. So not only is the disease more prevalent in some communities, but the impacts, the real human impacts of these diseases are really inequitably distributed. Two kind of last housekeeping notes before we get into the data. One on terms and definitions. When we talk about health equity and equity in general, we're talking about moving from the top left to the bottom left on this cartoon picture, from inequitably distributed resources and opportunity to creating custom systems in place to help give everyone the same opportunity to have a quality of life and health outcomes that they deserve. And specifically in metabolic disease, clearly we're in the upper left today. So as a quick tee up to the case study that's going to come from Dr. McKenzie, Virta Health's worked really hard to build those custom solutions to help address many of the underlying issues impacting diabetes. And this is because we had to. Our mission is to reverse type 2 diabetes in 100 million people, and there's no way to get there by just focusing on one group. So it's my honor to pass it over to Dr. Amy McKenzie to walk through our case study.
Thank you for the introduction. Before jumping in to show you the data of the people and the health outcomes of those who trust us to be a part of their diabetes care, I want to give you a little bit of background to share how we're thinking about this and what's kind of fueling our data analysis. So if you're new to the intersection between diabetes, social determinants of health, and the quest for achieving health equity, I want to invite you to read these two papers. One is a scientific review published in Diabetes Care by Dr. Felicia Hill-Briggs and her colleagues. The other is a perspective article in the Journal of Clinical Endocrinology and Metabolism by Dr. Sharita Hill-Golden and colleagues. And if these papers are familiar to you already, then that's awesome, and I invite you to share your favorites with me, but I wanted to start here as a foundation. And what these papers say is that past research shows that diabetes incidence is higher among people who earn less money, have lower rates of graduation from high school, or live in areas that have more single-parent households, among a number of other socioeconomic factors. Additionally, the stats tell us that diabetes is more prevalent among Hispanic, Black, Indigenous, and other people of color compared to non-Hispanic white people. And not only do these groups tend to have a higher prevalence of diabetes, but they also tend to have higher blood sugars, which puts them at higher risk of complications like needing the amputation that Kevin talked about, developing heart disease, kidney disease, eye disease. And that means that some groups bear a greater degree of the burden of diabetes, and it doesn't always stop at complications because some of these factors can also predict premature death. And these papers, I think, do a really eloquent job of laying out the medical and social historical factors that influence the disparities in diabetes that we see today. And they make a call for all of us to work towards health equity. Now, there are a number of ways that we can do that, from education and advocacy to data analysis and action based on insights, to use of evidence-based interventions and so much more. Today, I'm going to focus on what's shaping our approach and how we're beginning to use data in our quest to overcome disparities that we often see for people with type 2 diabetes. And we think that the first step is really to measure and to share and to begin that discussion. And that's where we are today. So there are many different ways that we can form groups between which we want to achieve equitable health outcomes. Today, we're going to talk about neighborhood socioeconomic conditions and race and ethnicity, though we acknowledge that there are certainly many more ways that we could look at the data in the future. And within these areas, we wanted to start with some very basic questions to open up that discussion. And we wanted to learn about who we were reaching, who we were treating, and how we were influencing their diabetes outcomes. So let's start with the socioeconomic conditions of the area in which someone lives. So Kevin introduced social determinants of health, and these are the social and environmental conditions in which we're born, grow up, live, and work that influence health and our access to quality health care. And some of these factors can be assessed at an individual level or at a neighborhood or geographical level. And the individual level is super important, especially working one-on-one with people. But we've also seen that geography matters too. And it's becoming increasingly used in large studies, and it's one of the critical things needed that we need in order to make progress and to all be speaking the same language. So today we're looking at socioeconomic conditions of the area in which one lives, using measures that other people have used in their research as well, so that we can all be talking the same language and we can start the conversation. And we're also using geography because we've learned how important it is. And the reason for that is because it reflects decades of structural inequities that were caused by laws and policies and practices that are no longer in place today, but the consequences of them live on. So, for example, after the Civil War, laws prevented Black people and other minority groups from living in the suburbs. That essentially segregated them into urban housing areas, and those areas later received less funding and experienced zoning restrictions that created inequities in things like schools and recreation areas and supermarkets. And all of these things impact diabetes care today, so you can see how it kind of comes full circle. Now, there's a measure that researchers can use to account for and consider some of the social determinants of health that exist within a geographic area. And that measure is called the Area Deprivation Index, or ADI for short. And the way that the Area Deprivation Index works is we take a geographical area. In this case, it's the geographical space that makes up a census block, and a score is assigned to that area. And the score is determined by characteristics of the area pertaining to income, employment, education, household characteristics, and the quality of the housing. So, for example, it considers things like median family income, median housing value, the percentage of people who achieve certain levels of education, or the percentage of households with access to a telephone. And these geographic areas are then ranked by their scores, and they're grouped into percentiles so that we can put them on essentially an index from 0 to 100. And then in research, these scores are often split into groups. In this case, we're using quintiles or fifths, ranging from the least to the most disadvantaged. So 5 groups spanning from 1, which includes the areas in our nation with the least socioeconomic disadvantage, the areas most well off, to 3, reflecting the middle 20% of the nation, to 5, the top 20% of areas in our country with the greatest disadvantage based on the socioeconomic conditions of their area. Now, past research has shown us that people living in more disadvantaged areas, the ones in the higher numbered quintiles, tend to have worse health outcomes. So let's talk about diabetes care as an example. We utilize a blood test called hemoglobin A1C that serves as a marker for how much glucose was circulating in someone's blood over the last 3 months. And the reason we care so much about this marker, about the A1C, is because the higher the A1C, the greater the chance of complications like kidney or eye or nerve disease. So what's a good A1C that we expect will reduce the risk of these burdensome complications? Many of you are probably familiar with HEDIS, and they broadly use an A1C less than 8. The American Diabetes Association says that it would be good for most people to be under 7. American Association of Clinical Endocrinologists recommends 6.5 or less. And at Virta, we typically aim for less than 6.5 whenever possible. And there was a paper published just a few years ago that looked at data from primary care practices in a major health system in the Midwest. And they found that the likelihood of achieving an A1C less than 8, the target that HEDIS uses, was less for people who lived in the most disadvantaged areas using this index compared to those who lived in the least disadvantaged areas. And that means that people in the most disadvantaged areas had higher A1Cs than the people in the least disadvantaged areas. So in diabetes care, this is a gap that we want to be able to close because everyone deserves to have good blood sugar levels regardless of where they live. So we talk about A1C a lot because it's this proxy for complications that might arise. But I wanted to kind of translate what this A1C means to you in real life. Kevin talked a little bit about this, but I want to help us understand the human element a little bit more. So here's a map, and the blue areas on the map are representative of the least disadvantaged areas in the country when it comes to those socioeconomic factors we talked about. The red areas are the most disadvantaged, areas with the lowest household incomes, lowest levels of education, highest prevalence of single-parent households, et cetera. And if we zoom in on some areas of the country, so for example, Columbia, South Carolina, and Houston, Texas, we can see the difference that just a few miles makes. In Columbia, if we look at the northern area, diabetes affects 10% of residents. It's also a food desert. What this does for patients is it creates problems with them accessing the appropriate foods that they need to keep their blood sugar into the goal range. Often their blood sugar runs too high. When it runs too high, they have problems with their nerve and their circulatory system. And on top of that, people in this area lack access to comprehensive primary care where they can go to a doctor to have their feet checked on to make sure that everything is okay. And consequently, what we see in this area is high rates of amputation. If we go just a few miles over into the blue areas, it's not the case. Next, if we jump down to Houston, some areas in the northeastern section of Houston, diabetes is affecting 21% of people, almost double the national prevalence, and much more than a few neighborhoods over in the Rice military area where prevalence is only 6%. In Northeast Houston, residents experience power outages and unstable housing conditions. So now let's put ourselves in the shoes of a person with diabetes. Imagine that we are taking insulin because our blood sugar is very high, and that's the most affordable medicine that our doctor can give us to lower our blood sugar into the goal range. Insulin, however, has to be refrigerated. Now imagine that while we're out at work, the power goes out at home, the insulin in our refrigerator goes bad. Do we have the time to go pick up more insulin? Do we have the money to afford replacing the vials that were lost? And if we don't have the means to do that, what does it mean? Do we just not take our insulin as prescribed and simply let our blood sugar run high? Because that's the only option that we have. And now you start to see the impact that geography can have on people with diabetes and how it's affecting their daily lives. So now I want to switch gears a little bit and move from the global picture of health equity and the problems that we're facing in diabetes and start to look at the patients that we're treating in our own clinic. So at Virta, we enroll people living with type 2 diabetes nationwide. And these data show that people choosing Virta live in a wide variety of neighborhoods, ranging from people living in areas with the least disadvantage in that first quintile in blue on the left, to those living in the most disadvantaged areas of the country in red, quintile 5 on the right side of the graph. I was both surprised and unsurprised when I saw these data for the first time, given how people have access to Virta, often through employer-sponsored insurance, through health plans, and even through just paying on their own. The skew towards the more advantaged neighborhoods was somewhat expected. Yet still, we have over a quarter of our patients coming from the top 40% of the most disadvantaged area in the nation. And here's another thing that surprised me. If we compare this breakdown of our own patients to a membership of large health plans, some of them have published their membership distribution by ADI quintile in journals, and they see a bell-shaped distribution. And one of them had 13% of their members in the most disadvantaged quintile, in quintile 5 in red on the right. We have 10%, and it's not so far off. So I think that this is really important to point out because often we get asked if we can reach people with more socioeconomic disadvantage. And when I ask, why do you ask that? They often say that they fear that Virta is only for the elite, the well-off, the people with enough time or resources or money to be able to make a lifestyle change. And I think that's a very reasonable and fair thought to have. And now what we're seeing in the data is that that may not be the case because we are enrolling people who are coming from these areas that tend to have a little bit more disadvantage. Would we like to see more access to Virta among people living in the most disadvantaged areas of the country? Yes, of course we would. We think that they deserve to have access to this as well. And we're working on forging new partnerships to bring access to Virta to people in more disadvantaged areas. Next question that we have is, yes, we are enrolling people in a wide range of socioeconomic conditions, but can we actually improve their diabetes? Remember, A1C is that marker of blood sugar that we look at in diabetes because it's a proxy for risk of complications. When it's high, we're worried about complications. So we try to lower it below 7, below 6.5 if possible. Here we see that A1C starts above goal for people who live in areas with all different levels of socioeconomic disadvantage. And across all groups, A1C improves by 1.2 or 1.3 and falls into the goal range for the majority of the individuals in each of those groups. So this graph shows that people living in all types of neighborhood socioeconomic conditions can succeed with Virta and improve their diabetes. On average, every group falls below the ADA treatment target of A1C less than 7. Some groups come below 6.5, which is our target here at Virta, and most groups reach the American Association of Clinical Endocrinologists target of 6.5 or less. Is it perfectly equitable from a pure numbers perspective? No, of course not. Are we always working to try to improve these and make it better? Absolutely. The other change that's happening alongside these improvements in A1C is that medications for diabetes are being deprescribed because they're no longer needed when A1C is lowered and blood sugar is no longer high. So in each of the ADI quintiles, over half of diabetes meds other than metformin were deprescribed because glucose improved. And the numbers for deprescription range from 53 to 58% across each of the groups. And I think this is important to think about, particularly for people with financial barriers to affording their diabetes medication, because as we reduce the need for medication, we also reduce out-of-pocket costs, and it's a tool that we might be able to use to help people achieve better blood sugar control without the added cost of medication. So let's take a look at this data another way. I talked a lot about A1C targets and the importance of them, and I mentioned that HEDIS uses a measure of A1C less than 8 as a quality metric. And I also mentioned to you earlier that in past research, the likelihood of achieving A1C less than 8 was influenced by the neighborhood in which one lives. And we see that relationship when patients come to us. The percentage of patients meeting the A1C less than 8 HEDIS target and enrollment in VERTA is exactly what we would expect, between 50 and 69% based on the HEDIS data that's published on NCQA's website. And it's reflective of what's happening across commercial and Medicare lines of insurance across the United States. But 6 months into VERTA, we see that over 94% of patients are reaching the HEDIS target of an A1C less than 8. Not only is that a big increase, but we're also starting to see the gaps between neighborhoods start to become smaller. You might be wondering kind of what we're doing behind the scenes to help facilitate this, to help overcome some of these factors that might be playing a role. And many times, people have concerns about eating low carb and think that it might be expensive. And that's true. It absolutely can be, just like the standard American diet can be expensive. But the key is that it doesn't have to be. When we know that people are living in a variety of different conditions with different resources available to them, whether that be their monthly food budget or the distance they live from the grocery store. So we have a wide range of resources available to them to help meet those needs. So here you see some of the examples of the resources available to our patients who are very budget conscious. And it includes everything from tips on shopping to sample meal plans. And you see the sample meal plan here. Many of the things that you see here come in at less than $2.50 per serving. The cost of fruits and vegetables is often a concern, but we've found ways to make it possible to get 5 servings of vegetables in a day for $1.25 or less. And beyond these resources, we have health coaches that can work with people one-on-one to understand their unique needs and find ways to work with them. So with some careful planning, we've even been able to find ways for people to eat things like scrambled eggs with spinach and cream cheese, chicken Caesar salads, fajita bowls, all for about $3 a day. So we've seen that regardless of the socioeconomic conditions of the area in which one lives, people can make significant improvements in their diabetes. You also heard me talk a lot about geography and why that matters because of historical laws and policies and practices that were related to race and ethnicity that had economic and educational consequences that kind of carry over into the diabetes outcomes that we see today. And racial and ethnic backgrounds of people can intersect with geography, but it isn't a factor that's considered in the Area Deprivation Index. And today, race and ethnicity certainly don't intersect perfectly with geography. So we think it's absolutely important to look at outcomes by race and ethnicity separate from and above and beyond geography or other socioeconomic factors to be able to tease these items apart. And when it comes to diabetes, Black, Hispanic, Indigenous, and other minority groups experience a higher prevalence of diabetes. So we want to be able to take a look at what's happening in each of the race and ethnicity groups individually as well. And we'll take a look at that next. So first, who's choosing to enroll in VERTA? About a third of people enrolling in VERTA identify as a historically underrepresented racial or ethnic group. 13% are Black or African American, 12% Hispanic, 5% Asian, and 3% American Indian, Alaska Native, Pacific Islander, Native Hawaiian, or are of multiple races. Next, we wanted to know if our patient population in blue was representative of the population with type 2 diabetes that's seen within employer-sponsored insurance, which is shown in the green bars. It's fairly similar, but there's clear opportunity for us to be able to enroll more people with type 2 diabetes who identify as Asian or Hispanic. And the other thing that we don't know is whether these groups are less frequently enrolling in Virta, or if diversity was lacking in the groups who gained access to Virta. And this kind of brings to the forefront a common challenge in data availability that just want to advocate for a little bit. And I think everyone who's been working in this area has run into challenges related to data availability and how critical it is that we need to work together to have data, to have good data, to make it available so that we can all learn as much as possible and then turn that insight into action. Next, we realized that the distribution of people with type 2 diabetes among those with employer-sponsored insurance is a little bit different from the entire population with type 2 diabetes throughout the United States, regardless of where their insurance comes from. There's a little bit of a shift from being more heavily loaded into the non-Hispanic white people and shift towards a higher percentage of people who are Hispanic, Black, Indigenous, and other people of color having diabetes. So we put our patient population in blue here on this graph side by side with an estimate of the broader type 2 population in the US, which is shown in the gray bars. And here we see even more opportunity. And I know that many of the Virta team are working very hard to build partnerships outside of employer-sponsored insurance, particularly with government health plans and Medicare Advantage plans, to be able to broaden our ability to positively impact many of the groups who are living with that higher prevalence and burden of type 2. Next, we wanted to dive into the outcomes to see how Virta impacts diabetes in each of the racial and ethnic groups. We see that A1C improves in each of the groups in just 6 months. These improvements are critical because not only do Hispanic, Black, Indigenous, and other people of color experience higher rates of diabetes, but they also bear this greater burden when it comes to complications. We know that every 1% decrease in A1C is associated with a decreased risk of death and complications from diabetes. And this is things like a 21% decrease in risk of death from diabetes, 14% decreased risk in heart attack, 12% decreased risk of stroke, 37% decrease in the risk of some types of eye and kidney disease, and a 43% decrease in the risk of amputation or death from peripheral vascular disease. And much like we saw before, as blood sugar improves, people need less medication to lower blood sugar. And here also, we observed reductions in diabetes medications other than metformin of 52 to 59% across each of the racial and ethnic groups. Another kind of peek behind the scenes to show you one of the ways that we are working to culturally tailor our care. One thing that we know is critically important across many cultures is food, and especially sharing time with others around food. And here we are at Virta teaching people about how food impacts their blood sugar. And many times people learn that the food that's culturally very important to them makes their blood sugar go up and stay up. And it stays up higher than they would like. So our team has put together a number of different recipes to help people match the tastes that are really important to them with the cultural experiences and traditions that are also very important to them. And the health coaches play a huge supporting role in working with each person one-on-one to do this. So I've shared a lot of information with you today, but I think that there's one more thing that I really want to share. And it's that thinking about health equity is not a one-time thing. It has to be this ongoing iterative process with continued learning. So we're continuing to look at places where there are gaps in diabetes care broadly and where we might be able to help close them, as well as ways that we can improve ourselves within our own care that we provide to our patients. After this first look that we've shared publicly, we kept digging and we've taken a longer term look at outcomes of our patients, and we've deep dived into the medications. And we just found out that research was accepted for presentation at the American Diabetes Association scientific sessions in June this year. So if you'll be there, we very much look forward to sharing the data and outcomes with you then. And if not, then we certainly look forward to sharing it with you after the conference and the embargo is lifted. So thank you so much for taking a look at diabetes care through a few different health equity lenses with me today. I am going to pass it back to Kevin to continue the conversation in our fireside chat.
Thanks so much, Dr. McKenzie. Really appreciate it. Well, I'd love to move over to Michael now, our expert with us today. Michael, what's your reaction to this data and analysis? Would love to hear you just put it in context for us.
Sure. And thanks for having me today. I always get a little queasy when I'm called a health equity expert because I'm also on my journey, just like organizations are. So I think it's great progress to see that we are, and Verda is taking a look at data, and actually not just looking for data, but also interventions around race and ethnicity in terms of type 2 diabetes. I just have to say, though, that the Institute of Medicine 20 years ago came out with their report called Unequal Treatment, where they said we need to do something in the healthcare system to address health disparities. Part of it is having the humility to say that there are health disparities, whether it's Medicare, Medicaid, employer-sponsored insurance plans, or what have you. And one of the recommendations that came out of that report was collecting and analyzing data based on race and ethnicity, which you demonstrated today, Dr. McKenzie, showed all that data. The other piece, too, is that another Institute of Medicine report from 22 years ago identified that the 6 aims of a high-quality healthcare system are safe, timely, effective, efficient, equitable, and patient-centered. And so the work here around health equity really aligns with what the recommendations were from the Institute of Medicine 22 years ago. And in the time I've been in healthcare, I've seen a lot of work around 5 of the 6 aims. But this one on equity is just beginning to get some traction. And frankly, the Centers for Medicare and Medicaid Services has really jump-started its work on health equity and requiring Medicaid agencies and Medicaid managed care organizations, Medicare Advantage plans, and so forth to focus on health equity, which they have been doing for a while. And employer-sponsored insurance plans are just beginning to do this work. So I think the importance is that this is the beginning. I think that you're going to want people like Dr. McKenzie around for a while because we're going to need more data analytics and data scientists. We today looked at race and ethnicity. I think there's other areas like people with disabilities, veterans, sexual orientation, gender identity, and even to get more granular, incorporating this concept of the intersectionality of our identity. So we're not just our race or ethnicity or gender or veteran status or whatever, we're all those. And can we get more granular with the data? So I applaud the work that you've been doing and Dr. McKenzie's outlining of the impact of the work. I just think we just continue to go. I think also I would say that most of the initiatives around health equity have started with race and ethnicity. And then I think it's a roadmap into what other populations. I think also health plans and other healthcare organizations are getting pushed now by accreditation. So the Joint Commission has accreditation that incorporates health equity. NCQA does. URAC's working on theirs. So there's going to be more pressure from the regulators and hopefully plan sponsors to continue this journey.
Thanks so much. So it sounds like not a newly identified problem. This is decades ago we realized it was an issue, but maybe you're seeing some signs of real traction on it recently. Yeah. Where are some other areas you're seeing digital health close some of these gaps?
Sure. So I want to start off by saying that I'm pro technology. I think it's great that we have this escalation in the use of virtual care. I think it's addressed a number of things. One is allowing increased access for many to access services, late at night, when you put the kids to bed or your aging parents to bed or what have you. And then you can do it confidentially, particularly with behavioral health, that you don't need to drive up to, the psychiatric clinic and everyone knows you're parked there, particularly in rural areas. So I think that it's really given the opportunity for many people to have improved access. There are some challenges with digital health. One is, do people have the broadband requirements? Do they have the devices to access digital health? That's one consideration. The other is there's been some studies about the use of digital health, and there are variations in the preferences of use of digital health based on race, ethnicity, gender, languages spoken, and so forth. So we see lower use of digital health solutions for people who have limited English proficiency. We say some racial and ethnic communities prefer voice as opposed to actually using an app. So I think key here is having multi-channel, fancy way to saying access through video, audio, texting, and what have you to meet the preferences but also bearing in mind the requirements for the use of broadband for people that live in rural areas or people in certain urban areas of low socioeconomic status that may not have, again, the broadband or the devices available to them. I think the other key too with digital solutions, particularly apps, is making them accessible for people with vision loss, hearing loss, limited English proficiency, color blindness, to just have a perspective on making sure that the digital health solutions meet the needs of everyone as much as possible to advance the health status of individuals.
So it sounds like you see a lot of opportunities for digital health to close some of those gaps, but also, if not designed thoughtfully, could actually exacerbate in some cases the challenges. Is that a fair summary?
Yeah, exactly. I think in some ways, people with disabilities are often overlooked. Again, I think the focus in terms of the subpopulations have been race and ethnicity. And when I talk to, honestly, Kevin, to some digital health solutions I mentioned, is it accessible for people with vision loss or hearing loss? They're like, what? Like, it's like a new concept. Like, come on, there are people that in the workforce, 25% of the workforce have some kind of disability, whether it's apparent or non-apparent, and just having a line of, a perspective in terms of meeting their needs to be as comprehensive as possible.
Well, you just mentioned the workforce, and we do have a fairly large number of participants today who are benefits leaders and leaders within people teams at companies, also some health plan executives. How would you advise them to map their solutions to health equity and drive change within their organization?
Sure. Well, first of all, I would say Dr. McKenzie is going to have a long career because she's going to be in high demand and people like her, because I think you have to start with the data. And I totally agree with that. Looking at the data, usually again from race and ethnicity, but you can also look at it from gender, looking at it from an intersectionality, like Black women, if you have ages, between the ages of 30 and 35, and are there disparities for that specific population? So looking at the data analytics and then really identifying where your health disparities are. I think that's a key step. Another key step is aligning your DEI or health equity benefit strategy with your organization-wide strategy. I see a lot of times there's a disconnect between benefit leaders and the chief diversity officer or similarly titled individual that leads the diversity, equity, and inclusion work of an organization. So taking a look at that strategy and developing your own in terms of benefits specifically. I think another key thing for benefit leaders to do is to look at your benefits with the lens of health equity. And so I was thinking in terms of, for example, a couple of ideas for with diabetes is, do you have coverage for podiatrists for foot exams? Because we know in diabetes, annual foot exams are important, or eye care, because we want retinal eye exams with people with diabetes. Do you have coverage for prosthetics for those individuals who are not able to achieve reversal? Because as Dr. McKenzie mentioned, there's a huge number of amputations that occur with people with this with diabetes. So just taking a look at your coverage from that lens. And then I think another intervention that benefit leaders can do is then take a look at what are you looking for from your vendors in terms of supporting or suppliers in supporting health equity. What are the kinds of requirements that you want? You want them to identify and address social determinants of health. You want them to have health equity initiatives. You want to have accessible websites and apps, and so forth. So coming up with kind of that laundry list of things. I forgot to mention in terms of data collection, I would also recommend, in addition to the quantitative work that Dr. McKenzie did, I think qualitative data gathering is important. So turning to your employee resource groups, for example, and find out from them what's working for them with benefits, what's not working, what's missing, what limitations of inclusion and benefits do they struggle with, and so forth. Anyway, another key thing would be to communicate transparently to your employees, to your board of directors, to the community about what you're doing around health equity. And then ultimately, you want to have that ongoing reporting out of your progress and your barriers and your new initiatives you're going to have around health equity. I think in preparing for this, I thought about kind of 4 key things that are needed to be successful. One is ongoing sustained leadership support for health equity. Another one is allocating the necessary resources for the health equity work. We know in organizations, there's a huge turnover in the chief diversity officers, and this is primarily due to lack of resources. So they say, okay, here's our CDO, but they don't give them the tools and resources to do their work. Ensure organization-wide commitment and prioritization. So, as benefit leaders, talking about health equity at every meeting you have with your vendors. What are you doing around health equity? What's the progress? What are the barriers? What's your roadmap, and so forth. And then the last one, which is Dr. McKenzie mentioned, which was embrace this journey. So this is not an endpoint. This is a process. And as Verda has started identifying and addressing, race and ethnicity, maybe the next one is veterans or sexual orientation or gender identity or people with disabilities or what have you. And so it's not like, check, you're done. It's like, okay, that's the benchmark. We continue on and we're going to work on the next thing.
So to pick up on one of the points you just made about ensuring health equity is a part of all of these conversations, recognizing that all organizations are evolving in this area, some of the research is quite new. How would you, if you were in those shoes or in the role of a benefits administrator, how would you hold your external partners and vendors to a higher standard on health equity? What are some of the things you consider?
Yeah, so of course, going back to data, Dr. McKenzie, so selecting nationally recognized, valid, reliable measures. Now we have the advantage with diabetes that we have very clear evidence-based clinical guidelines with very clear, like the hemoglobin A1C control, eye exams, foot exams, and so forth. Turning to nationally recognized measures like HEDIS, for example, is important. So identify what those measures are. Where do you want it to be? What are the disparities? Where do you want the improvements to be? Being really clear about measurement and improvement expectations and what are the interventions to get there. I think also when we talk about measures, I think about them in kind of 3 buckets. One is clinical quality, which the hemoglobin A1C certainly is a key one, and particularly diabetes. Another one is patient experience. So you can have someone, provider that does something clinically correct, but the experience is a negative one. And I think particularly the challenges that people of color have had with the healthcare system, negative experience. So the right thing may have been done, but the experience was bad. And then health service utilization. And I think Dr. McKenzie referenced that. So things like emergency department visits, hospitalizations, you want to lower those. You may want to actually increase primary care visits and use of home health and hospice and so forth. So looking at kind of those buckets of data, I think are really important. So that's a way to keep people accountable. Another way to look at it is prevention and preventive services as well as chronic care services. And today we've been talking about chronic care services. So getting measures, making sure that they're standard, reliable, valid, identifying what the benchmarks, and then holding them accountable with transparent reporting. Easier said than done.
Great, thank you. One of the topics that you talked a lot about when we caught up kind of ahead of the webinar was a distinction you made between social risk and social need. Could you talk a little bit more about that?
Yeah, so Dr. McKenzie talked about the social determinants of health. Some people call it influencers, or CMS talks about health-related social needs, HRSNs. When we talk about social risk, what that means is there's been some kind of analysis on a population basis of people who may be at risk for particular social needs, housing, transportation, and so forth. It doesn't mean that an individual member has a social need, but it means that that population is at risk. And certainly identifying social risk is important. I have found, frankly, Kevin, that sometimes you have to demonstrate that to large plan sponsors who may not realize that their members have social risks. And as Dr. McKenzie pointed out, your population is 25%. A study that I've seen says 27% of people covered under employer-sponsored insurance plans are at risk because of where they live and work. But social needs is something that is assessed when you actually have an individual member across from you, and there's a variety of different standardized tools that can be used, the PropHare, the health-related social needs from CMS and so forth. And what I say is, I don't care what tool you use, but you need to assess it. Just because where someone lives doesn't mean they have a social need. And then the next step is making referrals to community-based organizations to meet those needs, transportation, food, and what have you, and then monitoring for outcome and reporting on those outcomes. So many plans have contracted with community-based organization networks, CBO networks, so that when their employees identify social need, they can make referrals in a timely manner. But then I also say, let's take a look at then, what are the outcomes? Did they actually get the services from the CBO? And I think Dr. McKenzie showed, like, here's, food insecurity was one, and access to primary care can be another, and so forth. And then was there sustained use of those CBO services to meet the ongoing social needs of that population?
Thank you so much. I know we've been getting some questions from the audience, so we're going to transition to Q&A here in just a second for either Michael or Dr. McKenzie. So feel free to continue sending those questions in through the Q&A piece. We're also going to quickly put up a poll just to get feedback. Again, we offer these webinars. We want to make sure we're bringing topics out to the broader community that are adding to the conversation. So please share your feedback in the poll over the next several seconds. And in the meantime, we'll jump into some of the Q&A. So first question from the audience, and I think maybe Dr. McKenzie, you can talk about this from a Virta point of view, and then Michael would love your thoughts as well. What's your experience with health equity for seniors on Medicare versus a younger population on employee plans, and maybe how that differs? So Dr. McKenzie and then Michael.
Sure. From a data perspective, the answer is that it doesn't differ very much. Forgive me for reading. I want to give you the right outcomes. We did look at patients with who are older, age 65 plus, as sort of a proxy for Medicare eligible. And we saw a 1% unit reduction in A1C from 7.6. 56% of diabetes meds other than metformin were eliminated, and weight loss of 10% was achieved at 1 year. And this very much aligns with what we're seeing in younger populations, as well as what we saw in our clinical trial, which only enrolled up to 65. Then when we look at, we did another split of people who are older, who were coming to us with higher A1Cs, the people who are at greater risk of complications. And we looked at among people who had a starting A1C when they joined us of 8 or higher. And these people had an A1C reduction of 2.1 from 9.2, eliminated 46% of the medications other than metformin that they take for diabetes, and lost 9.3% of their body weight. So generally, we're seeing a very consistent response. And that is very common, not only for us, but also for other lifestyle interventions.
And thanks, Dr. McKenzie. I would say a couple things. One is there's several steps in the process. I'm a case manager by background, so there's several steps in the process. One is, do they live in a food desert? 2 would be, how do they get access to healthy, nutritious food? How do they afford it? Which you addressed, Dr. McKenzie, in terms of the kinds of diets you have. Can they prepare the food? Do they have electricity? Do they have gas? Do they have a microwave? And I think about seniors, like, they may just have a microwave. And then adapting the meal planning process to that. The other one, which you also touched on, was the cultural cuisine. And that can be just tricky. If you have someone, part of my heritage is Italian. And so, like, eating a lot of pasta is probably not the best if you've got type 2 diabetes. And so how do you adjust that? I've done that in my own life in terms of using different kinds of ways to prepare foods that are lower carb and healthier. The other thing that I would say is there was a study that showed that just putting a comprehensive grocery store in a neighborhood doesn't change actually obesity. Because the other piece that has to happen is the meal planning portion of it. Because if you've not done that, it's like, okay, here's the grocery store. with all these wonderful things, but if you've not had an experience with how to prepare fresh produce or healthy, nutritious food, then it doesn't impact obesity or weight levels. So that's another piece in terms of a societal intervention.
Thank you both. Another one that I'll pass over to Dr. McKenzie and then Michael also. Do you use community healthcare workers to engage patients with historically low appointment keeping behavior? If so, what backgrounds do you look for in the community health worker?
Sure. We are actually just starting to look into this in research right now. So we have a study ongoing in the rural areas of Colorado because we've had a lot of experience with community health workers just being a bridge to people who are having trouble in keeping their appointments, people who live further away, people who need a little bit of extra support in their local healthcare system. So we're doing a study right now to look at adding Virta into that ecosystem with the community health workers to see if we can work together to bridge some of the gaps. I think that some of the key background things that are needed in community health workers is that they have to have a little bit of knowledge of nutrition. They need to have a little bit of knowledge around how to work with people with diabetes and what their main concerns are. A lot of what Michael Garrett is talking about in terms of kind of digging in and understanding all of the factors that play a role in someone's life. These are the people who can bridge the gap and really peel back the layers of the onion and help work with us as well to do that. And I think they have a huge role in helping to close gaps in diabetes care. So we're doing a research study now to learn if we can work together to improve outcomes. And in the next couple of years, I look forward to sharing those outcomes with you as well.
So community health workers have been around for some time, primarily in the Medicaid population. I have not seen them as part of a team for employer-sponsored insurance plans. One of the challenges is because they're not licensed. How do you pay for their services? There are one of the parts of the question was, what do you look for? There are certifications, national certifications for community health workers, there's already been studies to show the effectiveness of community health workers with the Medicaid population. I don't know specific with diabetes, but with other accessing preventive and chronic care services, so forth. And I actually think that's also true for other kind of paraprofessional roles that are not licensed, like, for example, maternity doulas, excuse me, which I know is off topic from diabetes, but that's just another example of using these kind of emerging paraprofessional individuals who can have a profound impact particularly for historically marginalized populations. So great that you're studying it, but it's well researched in the Medicaid populations. I just don't know that it's going to take traction with people covered under employer-sponsored insurance plans.
All right, next question from the audience. Reviewing data is valuable, but how would you recommend we collect qualitative feedback from our population on how different solutions are working in these areas? Maybe Michael and then Dr. McKenzie, if you have anything to add.
Yeah, I alluded to it. I think one is having a facilitated discussion with, for example, employee resource groups, if you have them, or diversity council. It's got to be a safe place for people to share information, because if they've had frustrations with benefit plan coverage or a particular health plan or employee assistance program or a disability carrier, it's got to be a safe place for them to talk about it. And I think, first engaging with the leaders of employee resource groups about, we'd like to do this, let's talk about how to make that happen. You could also do surveys, but, of course, surveys historically have poor response rates. And particularly if you're asking about pretty sensitive kinds of things, that might be difficult. I just think having facilitated discussion with employee resource groups, diversity council, affinity groups, whatever you call them, is a great way to collect qualitative data. The other piece, even though I just said, got to be careful with the surveys, is if you have an employee satisfaction or engagement survey, asking questions around race, ethnicity, maybe sexual orientation, gender identity on a voluntary self-identified basis and allowing people to say they decline to give that answer is another way to just kind of get a general sense of how satisfied or engaged your employees are.
Anything you'd add on that, Dr. McKenzie, on qualitative feedback?
I think I can only speak from my experience, but my experience is that people tend to speak up. So just to open your ears and listen, and You're going to hear whether things are great or terrible, and you might even be more likely that you hear if they're terrible. So just keep your door open and listen.
Thank you. Next question, I think, is targeted toward you, Dr. McKenzie. Any longitudinal data on control when meds are reduced and eliminated? And I'm going to assume that means weight control and A1C control. But if you want to talk to that on longitudinal outcomes.
Sure. So we have looked at, when we started our trial, we did it for 2 years, and then we soon decided that we needed to extend it to 5 years. And this is kind of the key piece, right? Like as we utilize nutrition therapy with patients, A1C gets better, weight gets better, and then we are able to peel away some of those medications, but only as long as their A1C and their weight stays in a better range and their health is improved. So over 2 years, we saw that we were able to eliminate 67% of diabetes meds other than metformin, while patients maintained an A1C decrease of about 1. Obviously, if on an individual basis, I'm talking in averages from our clinical trial, but certainly on an individual basis for each patient, if we see a patient's A1C or weight starting to creep up, then our first approach is to, reattack from a nutrition perspective and say, what's going on? What can we optimize? What can we do different? And if that fails, then we go back to medications. But overall, on a whole, we're seeing people able to keep their A1C and weight down even after the medications come off.
Thank you so much. Maybe we'll try and get through 2 last questions in here. First, each piece of the healthcare system, PBM, health plan, case managers, digital therapies, et cetera, has some valuable social determinant of health resources. Do you have any tips for how providers can bring those resources to patients most effectively and efficiently? It's hard to keep track and connect the dots sometimes in real time. Michael, any thoughts there?
Yeah, I would say suggestion that I've seen some health systems do, not necessarily individual providers, but health systems, is either develop their own community-based organization network or contract with a community-based organization network so they can easily access that. There are free versions of these kinds of things as well as paid versions. And then having your case managers or discharge planners or social workers do the follow-up to make sure that they actually receive those services. I think hospitals are really still continue to be focused on avoiding readmissions. And so making sure that someone gets connected with community-based organization services, I think will help continue to drive this initiative to lower the hospital readmission rates by making sure that they receive services.
Great. I know we're just about at time, and one of our audience members has provided us with a great closing question that I'll pass to you both. What resources would you point us to for additional learning? Michael and then Dr. McKenzie. Well,
I think we're going to push out some of those resources to you to share. I think there's the National Alliance for Addressing Social Determinants of Health Issues. Depending on who you are, the American Hospital Association has Institute for Diversity and Inclusion. America's Health Insurance Plans has a similar health equity. The Institute of Health Care Improvement, IHI, has a health equity playbook. It kind of depends on where you are. Are you an employer? Are you a business group on health has health equity and social determinants of health issues? So it kind of depends on where you are in terms of what resources I would recommend.
Thank you so much. Dr. McKenzie, anything you'd add?
Sure. I did share 2 of the papers in my presentation today that I think are just absolutely formative when it comes to social determinants of health and how it intersects with diabetes. So one is called Social Determinants of Health and Diabetes, a Scientific Review, and it's in Diabetes Care. And the first author is Felicia Hill-Briggs. The other is called Casting a Health Equity Lens on Endocrinology and Diabetes by Sharita Hill-Golden, Josh Joseph, and Felicia Hill-Briggs in the Journal of Clinical Endocrinology and Metabolism. Michael mentioned IHI. There's also the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare that I think are very informative and can really inform how we provide care if you're on that end of the spectrum. And the other thing that I would say is your peers, and just to have conversations with your peers and hear what they think, share what you think, have a discussion. And sometimes those conversations that you have are some of the best resources.
Well, thank you again, both Michael and Dr. McKenzie, for joining us today for this conversation. Thank you to everyone who tuned in. We had several hundred here live on the line and 1,000 or so registered who will be seeing this asynchronously. We'll share some of the resources in the follow-up from that, as well as the recording of this video, and look forward to advancing this conversation and ultimately advancing outcomes to address so many of these gaps and needs. Thanks, everyone.